So thank you for joining us today for our webinar on HIV nPEP, the prophylactic medications that we prescribe to help prevent HIV transmission in our sexual assault patients. We know that this is an area that can be very stressful for SANE nurses to coordinate and can be very complicated. So we're very lucky to have with us today Bridget Montgomery to help go over the HIV nPEP process, why it's so important. We're going to be spending some time looking at the different forms that are available and leave you with some great resources to help you out. So I'm Nicole Broder. I'm the SANE coordinator with the Oregon Sexual Assault Task Force. I'm very grateful to get the chance to put on this webinar through our OVW rural grant. And so we will be spending a little time as well today talking about rural considerations for nPEP, some of the additional challenges that presents, and kind of how to troubleshoot that. I'm going to let Bridget introduce herself here.
Hello, everyone. This is Bridget Montgomery. I'm a SANE here in Oregon. I happen to have worked in HIV in my prior incantation as a nurse, and so I had the pleasure of having the knowledge of how to obtain meds and the resources that are available to our patients. So I think we would like you to actively participate. You have a chat box and a place where questions can be submitted, and I welcome you to do that so that we can not only have this presentation, but address any specific things that have come up in your practice today.
Yeah, especially if you notice that anything that we're talking about jogs your memory about specific patients or challenges that you've had, we definitely welcome you to contribute that, like Bridget said, in either the questions tab or the chat. I'll be keeping an eye on those, and we're happy to address them as they come up or towards the end, depending on what seems most fitting at the time. So please do feel free to share your own experiences so that we can make sure this is as relevant to you as possible.
So what is our role in helping patients who have presented for sexual assault, post-assault care, possibly evidence collection, and how we can, so what's our role? Okay, so we're responsible to educate the patients so that they have the ability to make an informed decision to proceed with post-exposure prophylaxis or to not. And we're going to go through the data that's available so we can present that to our patients in a logical way for them to be able to make that decision. We of course work with the providers and the staffs towards that same goal at the facility where we're doing the exam, and if needed, facilitate medication patient assistance for patients who either who are uninsured or cannot pay for the medications or underinsured.
And one of the things that's so important about this in regards to SANEs is that even though most of us will not be prescribing because most of us are not providers, a lot of times we will have the most up-to-date knowledge on nPEP, on the recommendations, and on these resources. So it's really important to have these tools in your back pocket as we go along here. Just notice there's a question, is the PowerPoint available for download? And when we do post this on the website, we will make that available, especially because we do have a lot of links that will be later on in the PowerPoint. So we will be posting this PowerPoint online in about a week or two, and we'll include the PowerPoint itself and then also a resource guide that Bridget put together for us. And we'll be kind of discussing some of the other things as well there.
So we're going to start with spend a little time on the basics of HIV. What do we need to know about it so we can educate our patients? So we need to know what HIV is, how it's transmitted. We need to be educated on the risks of transmission based on exposure. The pre-treatment workup, meaning the tests that need to be drawn prior to starting nPEP, and the medications themselves, the dosing, the side effects, and the treatment course, because we are responsible for that education if we start patients on the medications at time of exam. And of course, we need to know how to work the assistance programs to get the medications to the patients in a timely manner. That falls into our responsibility working with the providers who would be doing the actual prescribing. So what is HIV? I won't spend too much time on this. I think most of us know. It's an immunodeficiency virus. It's a retroviruses. And the nature of retroviruses are that they insert themselves into a host cell. And then they basically invade that cell and the nucleus of that, and it starts to then become a factory for more HIV viruses. And in the process, really destroys that host cell. They invade all cells that have a CD4 surface receptor, but primarily the issue, as you guys probably know, is T4 lymphocytes, because we always look, at a T cell count to find out how ill someone may be who actually has HIV. The ultimate endpoint is that once infected, our body is unable to fight infections and cancers, because the T lymphocytes are responsible for that kind of immune response. So this is just a picture. I don't have to spend much on it, but you can see in the upper left-hand corner that the virus comes in and basically incorporates itself into the nucleus of the cell and becomes a factory for more virons. I want to clarify, there's a few categories of post-exposure prophylaxis, and it's important to understand the differences. In terms of post-exposure prophylaxis, it's a treatment for a single high-risk event to stop seroconversion, meaning being infected with the HIV virus. There is occupational OPEP. That's for healthcare workers who have been somehow exposed through a cut, needle stick, or splash to potentially infectious materials. Then there's nPEP, which is what we're going to be talking about today. That is for non-occupational, that's the N, non-occupational exposures. And that's for individuals who are not healthcare workers, but somehow were potentially exposed to HIV through either consensual or forced intercourse or accidental punctures or IV drug use. Just a general idea of how things are in Oregon. This is from 2015. And as you can see nationally, the dark purple is where sort of that highest rate per 100,000 population. And we're on the lighter end. You see up at the upper left-hand corner. And these are actually like the rates of adults, adolescents known to be living and diagnosed with HIV infection. So we will just give you an idea of sort of how that spreads out. We're in a lower risk area in this part of the country. So how do we evaluate for nPEP? Well, the first thing we need to do is to determine the HIV status of the patient, meaning what is their baseline status? Could this person have contracted HIV prior and is unaware? As probably most of you know, from the time of exposure to HIV and infection, individuals take 8 to 10 years before they present with symptoms like infections or a dropped T count. So people can go 8 years not knowing that they have the disease. The other thing we use for evaluation is what's the risk? of the HIV acquisition. And we're going to break this all down, but based on exposure of the type of exposure, the frequency exposure, and the known status of the person who, if it's known, the source person, or I guess we'd say the assailant, their HIV status. We're going to talk in more detail, but the evaluation also includes the date of the assault, because nPEP needs to be initiated within 72 hours from the point of exposure. If the 72 hours has passed, there's no evidence to support the efficacy of nPEP after 72 hours. And the goal is to start the medication as soon as possible. All right, so we're going to talk about the risks. One of the main points is, what body fluid was the patient exposed to? Blood, semen, saliva, urine, stool. All of these have very different potential for viral load in them. Do we know if the assailant has HIV? And of course, that's very rare in sexual assault, but there can be instances where the assailant is known to the patient and may know their status. And what's the exposure site? Is it vaginal, anal, oral? Is it in the eyes or on the skin? And of course, the number of exposures. We're going to go through the data on all of these. Other things to think about is comorbidities. If a patient or a victim or the assailant has genital or oral lesions, and the list here of sexually transmitted diseases, syphilis, chlamydia, gonorrhea, that can increase the risk of transmitting the disease. Obviously, if there's an injury at the exposure site, so perhaps a traumatic injury, a vaginal tear, or an abrasion of some sort, and that site is exposed to infected body fluids, it's more likely to penetrate the mucous membranes and infect the individual. How many assailants were there, and was there a condom used at the time of assault? So again, nPEP, it works, it's most effective when initiated as soon as possible. 72 hours is the cutoff. And this can be a little bit of a tricky part, these next few steps. It should be provided only for infrequent exposures. And by that, I mean, if you have a patient who has had multiple courses of post-exposure prophylaxis, a strong consideration is to direct that person to a provider to be placed on pre-exposure prophylaxis, which we will talk about. Many of the individuals we care for can have some high-risk behaviors. So if it's a sex worker or an IV drug user or anything of that nature, they're already at high risk for contracting the disease. So this is not to say that nPEP cannot be initiated again, but it is absolutely advised by the CDC that people who are at high risk, who have had multiple courses of nPEP, should be potentially treated again with nPEP, but really need to be getting on pre-exposure prophylaxis, which is a prophylactic treatment to decrease the risk of contracting the disease. And we'll talk about that in a second. So here's the pre-exposure prophylaxis. Basically, individuals are put on everyday lower dose, typically Truvada, and they will do that every day. And that the studies have shown that it's very effective for stopping HIV seroconversion. But it needs to be taken, like all the other meds, on time at a regular basis. I don't think this is something we will deal with very often, but you should be aware that if you're caring for somebody and this is their scenario, that a referral to somebody who will initiate this type of treatment or consider this type of treatment with the patient is really in their best interest. And the candidates, again, for that are people who have an HIV-positive sexual partner, a lot of sex partners, inconsistent or no condom use, commercial sex workers, maybe they live in a high prevalence network, or they have an HIV-positive injecting partner and share equipment. So those are things to kind of look for as you're, if that information comes forward in your interview with the patient. Okay, so how do we address HIV risk with our patients? It's, it can be difficult to be concise and explain in a way that patients can really understand, but not be so complex that the bigger picture message is lost. I have found using the data is the best vehicle for that. So the first thing we're going to look at is this. This is from the CDC. And this chart shows, and bear with me here, it is a per act risk, meaning per sexual act, okay, of acquiring HIV from an infected source. So do know this data is not derived from victims of sexual assault. Obviously, CDC is not going to conduct that type of a study, but they have hundreds of thousands of individuals who data has been collected on where they had a partner. So this is consensual partners who are HIV positive. And so this is a per act risk of contracting the disease in the scenario of consensual partners. So you see at the top, blood transfusion, obviously huge, and the needle sticks or needle sharing is quite high. Okay, and this is per 10,000 exposures, right, in terms of humans. Okay, so if we've got sexual, let's take a look here at receptive penile vaginal intercourse. So that's an HIV infected penis into a vagina that is not HIV positive. And so 8 in 10,000, the risk is 8 in 10,000. And basically what that gets down to is 0.08%. Typically people will quote 0.1% in terms of the risk. With insertive anal intercourse, this is the risk is higher, slightly higher. As you know, the anal sphincter, the rectum, was not designed to release muscle-wise, as a vagina is, and therefore it increases that risk of some traumatic injury, and there you have a portal for the HIV to enter the body. Sorry about that. So if we go down to things, and I think this comes up a lot. Can I move this? Mm-hmm. Patients who say perhaps semen was squirted onto their chest and there's no portal. And that's the only source that they're able, the only event or exposure they say occurred. Well, you've got a negligible risk for that type of exposure, unless the skin is somehow compromised. This is true for biting and spitting because sputum has very little to no HIV. It's negligible. And then the receptive, let's see, I want to show you one more. Hang on. So receptive oral intercourse. So an HIV infected penis with a not infected oral cavity of the victim. This is another situation where the risk is very, very low. They don't even have the numbers on it. It's a potential, but it's very, very low. I use this data and write out specifically the risk percentage once I've found out what's happened with the individual. If you're fortunate enough for the person to have not had a blackout period or something like that, and they were fully aware during the assault, and you're fairly certain that this has been their exposure, I actually write out the percentage on a piece of paper, because I think these are kind of weird concepts to try to explain when people are tired and trying to absorb this information. Yep. Why is it? Yep. Thank you. Mm-hmm. Okay, so how effective is it? The fact of the matter is, nPEP is not, there's never been there's no observational studies or case studies that have been done specifically for nPEP, meaning non-occupational exposures. The use of nPEP for non-occupational exposures, or this treatment, is based on data that came from occupational exposures, and there have been studies for that. In fact, thousands of healthcare workers who were exposed with needle stick type compromises or blood exposure were studied, and they found that using OPEP reduced the risk of seroconversion or being infected with HIV by 88%. Given that that is a hugely significant number, it's extrapolated to people who have got non-occupational exposures. We know it works for people who have been exposed at work. Ethically, they will now apply the same principles to people who have been exposed outside of the workplace.
Looks like we had a question on the last slide.
Okay. Okay.
So it said, why is there a difference between vaginal and rectal versus rectal and vaginal?
Okay. So, where are we at here? Just to make sure, so I think we're saying the receptive penile vaginal intercourse means versus with insertive. Okay. So one is addressing if the female is HIV positive and the male is not, the insertive penile vaginal intercourse. In that situation, it is a HIV positive female with a negative male, the insertive penile. So this is the risk of an infected female transmitting to a HIV negative male, which is lower than the receptive penile vaginal intercourse. That's an infected HIV positive male with his penis in a female that is not infected, and that's higher risk there because there's more chance of that of the penis causing trauma to the vaginal wall versus the other way around. Okay, is that our next one? Okay. So one thing that we also need to understand is that before someone gets started on nPEP, because the medications are greatly improved, but not without their risks, and because certain scenarios, certain clinical situations affect dosing as well as the person's risk of contracting the disease, this is the list of labs or tests that need to be conducted prior to administering the first dose, so at the time of exam. Obviously, if you look under where it says exposed person at the top of the slide, and under the category that says baseline, okay? Not the source line, because that's if you know the source. In our case, that would be the assailant. But for the exposed person, we need to make sure they're HIV negative, right, first. You're not going to start nPEP on somebody who unknowingly already had HIV and isn't infected. It's not the appropriate treatment course. We need to find out if they are actively infected with hepatitis B, if they are positive for hepatitis C, if they have syphilis, gonorrhea, chlamydia, and then obviously if they're pregnant. Pregnancy is not a contraindication for treatment, but sometimes there can be some medication changes to accommodate for that. And all of these tests, as you know, will not be back by time the person starts the medication at the end of the exam. In ideal situation, the institution has a rapid HIV test, and that will come back. If not, you do not delay treatment. You continue. You provide the medications. You provide the medications. You administer the first dose, and then the patient, which we'll get into, will need to have a follow-up appointment with a provider, and mostly these are primary care providers. I know there's institutions with there are an exception. Providence up in this area is one of those. They've created a system where their infectious disease team sees patients being put on nPEP, but that's unusual. But regardless, at that follow-up appointment, and we'll talk about it more, but the results of these tests will be reviewed, because the results of those tests may affect the dosing, the risk of the person, contracting the disease, and we'll get into a little more of it, but I'm going to give you one little example off the top of my head. The hepatitis B. So with Truvada, which is one of the meds, is the primary, first recommendation, one of the two meds. With Truvada, if somebody has an undiagnosed active Hep B and they go through nPEP treatment, and then they, at 28 days, stop the treatment, which is the protocol, they can have a sudden catastrophic reoccurrence of this Hep B that can cause great liver damage. So, okay, why would the doctor need to know about this when the patient follows up in a few days? If they see that they've got an active, undiagnosed, untreated active Hep B, they're probably going to start them also on another antiviral, and or they're going to monitor them a little more closely for potential side effects. If the patient's positive for, say, syphilis, gonorrhea, chlamydia, that puts them at a little bit higher risk for maybe contracting the disease or the transmission. And as we know, sometimes patients start the treatment, but then want to stop it. And with this information, the doctor can support whatever decision they make, but to at least inform them that they have these infections. It does increase your risk somewhat of contracting the disease. Then, of course, the bottom, we need to get, it says creatinine and the liver enzymes. Basically, most places will run a complete metabolic panel, and that would look for kidney function and liver function, as both of these meds can do damage, or most of the meds can do damage to both of those organs. And if someone has a compromised liver or kidney function, there's a decent possibility they're going to do a dose adjustment based on that information. I just got a question. So is it okay to give the first dose depending on liver results? So if you are fortunate enough to get those labs back that quickly, which I've rarely seen, I think if the liver function is greatly compromised, that would be, I would work with the provider to have them reach out to the ID person on call to ask if they feel like they needed to do a dose adjustment from the get-go, so that they're not, going 3 to 4 or 5 days with a dose that might not be appropriate for them. Does that answer your question? Hang on. I have a question. If you have a patient with a known alcohol abuse history, yes, absolutely. I think one of the biggest concerns with individuals who are, say truly alcoholic is their compliance or adherence to the protocol, which we'll get into. It is very important. I think anybody with addiction sometimes has some scheduling challenges, but unless there's an indication from the labs that maybe if the person's completely cirrhotic or something of that nature, and maybe that's known, that would be sort of an unusual situation. But again, I would have the provider call the ID person on call and ask if they should write for a dose reduction. But the general advice is do not forego starting nPEP, like if you don't have the HIV back or you don't have all of these tests, you proceed, because the most important thing is starting the medication as soon as possible, except for in rare situations. Why would we need okay, Rebecca, you asked a great question. Why would we need to do the baseline GC chlamydia test? We're going to treat it anyway, right? Yeah. So, we don't do that in any other scenario. But the reason we do it in this situation is because having those two and syphilis STIs increases their risk of contracting the disease. And so again, as you know, sometimes people get a few days out, they're not as certain if they want to keep on nPEP, but they will have a provider appointment at that time, and the provider can also at that time advise them, well, you do have this and this and this. It might increase your risk of having contracted the disease, but also that they would need to be followed up, after the fact. Let's see.
Okay. I think we're caught up on questions. Just double checking here. Okie doke.
All right. Keep sending questions though, please, guys, because, that's what, and think about if you've ever had any big scenarios or challenges along the way. All right, so the medications. By the way, there's going to be a written document that's going to be attached to all of this resources, okay, on the site and attached to the PowerPoint when we post it. So as you know, the first line treatment is Truvada and Isentress. Truvada is a once a day medication. Truvada is actually two medications combined, emtricitabine and tenofovir. That's why you've got the 200, 300. And then Isentress is strictly one medication. It's 400 milligrams, and it's given twice daily. The CDC recommended course is for 28 days. And put that in your head, because we're going to talk about when you try to get when you go to get medication assistance, you end up having to write for a longer course, but that has to do with the program. So 28 days from the, and if ideally you'll be able to give the first dose in the ER at the time of exam. Is that? We're reading a question here. I can't read all of it. One second.
Okay, so it looks like the question is if there's a patient who's unsure if they should get the nPEP, if it's okay to give them their first dose, fill out the application for reimbursement, and then if they choose not to continue, for them to stop. So is it okay to give them their first dose, even if we're not 100% sure that they will comply with the course? And that's definitely a situation that does get brought up.
Right. Yeah. And yes, I mean, it does come up a lot, and it's challenging. I think if the individual, our job is to facilitate the care that they are choosing for themselves, and I don't think the nPEP is certainly any different. So I would say, and I have always done, is of course you start them in the ER. Hopefully, you've got take-home packs and whatnot too, so that they'll have a couple days of treatment while you're working on the programs to obtain the meds. At least in my practice, most patients need that, need one of those programs. But yes, absolutely start them. There is one scenario I'll talk about later about the dosing and whatnot. But yes, start them, go through the process, make it available. And if at some point the individual chooses not to complete treatment, that's their individual choice.
Yeah, and I'll just jump on here too, because this does come up a lot, and I've found especially in coordinating with the providers, sometimes there's a lot of pushback if they feel like it's not 100% certainty that the patient is going to continue with the course. Maybe if there's mental illness that's being dealt with or houselessness that may provide barriers to getting the medications, things like that. And I do the same as Bridget, where if that's the patient's choice, I will coordinate that and facilitate them getting the meds. I just make sure to be very clear with them about the possible very dangerous side effects of not continuing or taking the meds without following up appropriately with a provider. But then if they do choose to not continue that course or to not follow up with the provider and take on those risks for themselves, then ultimately that is their choice. So as long as we do that education, we're doing our job. I kind of think of it like, I'm sure we've all been there when we've helped give antibiotics out, and we tell the patients, you need to take the whole course, otherwise, could end up with, resistant strains and whatnot. And probably a lot of those patients go home and don't take the whole course, as we know. But we do our education, we explain why it's so important, and then ultimately it is up to them whether or not to be responsible about it or not.
So there is an alternative to Isentress, which is Tivicay. and that is a once a day dosing. Just some notes here that there are guidelines for both renal dysfunction and weight adjustment for children, which I don't know how often pediatric exposures come up, but we've always operated that if it's someone under the age of 18, we've got to have infectious disease involved, and unfortunately, the way that the patient assistant programs are set up, someone under 18 can't sign for themselves on them, so the parent usually would have to be involved as well. Okay, so management, once somebody is getting ready to leave from the exam, assuming that they're starting on the nPEP, they've got hopefully a take-home pack, they've had their first dose. And I find this to be one of my biggest concerns and challenges, is that many people do not have a provider. So, and even if they do, being able to get in a timely manner. The first appointment really should be within 3 to 5 days of starting the treatment, after starting the treatment, because they need to go through these labs. They need to figure out if there's something else at play. They need to get more education, because the patient's not going to be absorbing everything you have to tell them, after an assault and an exam and all of that. So it is important to try and get facilitate the lab results being sent to the provider that's going to do the first visit. Now, what's challenging is sometimes we don't know what provider that's going to be. Sometimes you can get lucky and everybody's on Epic or something of that nature, but it is something that I've worked pretty hard to make sure happens. I'm going to go through, we'll show you, we'll open the link. There is a resource that works most of the time. There are things called if a person doesn't have a provider, there are these clinics called federally qualified health centers. And by definition, they are bound to get patients in a very timely manner, new patients, regardless of insurance. Insured, not insured, it doesn't matter. It has something to do with obtaining that type of qualification. It is an obligation that they need to meet. These centers also have benefits people and social workers and a bunch of other kinds of resources for patients. So they can also work to get this person onto insurance if needed. So they tend to be very good resources for our patients, in particular those who don't have a PCP that they can follow up with. I think, especially for programs that maybe are not so centrally located, there may be like 1 or 2 local federally qualified health centers in your area, and then maybe establishing a relationship with them about these referrals that you would send, or phone numbers that calls you might make for the patient, or you'd ask the patient to make themselves, that you can utilize that facility for patients that you're going to start on nPEP that don't have a PCP. There is also going to be attached, so you don't have to memorize, but we need to talk to patients about the side effects. And there are discharge instructions on the Sexual Assault Task Force website that are specific to nPEP, and on there it also outlines all of these, and the links it will give you to the meds themselves will also give you that resource. Truth be told, the medications are much better than they used to be. People used to always be sick. Sometimes people can take nPEP and not feel sick at all. Personally, my anecdotal experience is that many people will have sort of some GI upset, like nausea or some diarrhea, or just not, and they certainly, maybe don't feel well, like kind of maybe not fluish, but like with a cold, have a headache. So those are the common side effects for Truvada: feeling ill, kind of nausea, depressed mood. So there are some serious side effects, and these are ones we have to make sure that they understand when they leave. So if they start to have them, they know that they need to stop treatment and immediately, hopefully, go to the PCP that they're seeing or present to the ER. So lactic acidosis, worsening renal impairment, and again, the exacerbation of the Hep B virus post-treatment or an allergic reaction. And then there's a list here, oddly enough, they're not fully contraindicated, but with Truvada, the Advil, aspirin, Tylenol, Aleve, chemotherapy, there's a list here that have varying degrees of interaction. So I always advise that the patients avoid these if all possible. I mean, if they're on chemotherapy or other antivirals, and that's like another consideration. If they're in active treatment for cancer, that would be a good phone call to, for somebody to make to their oncologist or to ID about starting nPEP regardless. Anyway, dosing, 1 tab daily, which is wonderful. When you teach people about these meds, and we'll keep doing it, the thing to stress is it needs to be taken at the same time each day. If they've missed a dose and it's been a short period of time, they can go ahead and take it then, but they should never double up and take 2. So if you're close to the next dose, never double up and take 2. Isentress, similar profile for side effects, but the serious side effects for Isentress is Stevens-Johnson syndrome. I think we all know what that is, and rhabdomyolysis, liver failure, kidney failure, hives / allergic reaction. And there is a pretty decent drug-drug interaction with aluminum or magnesium containing products. So people should not take those meds, or if they do, they take it 4 hours after they've taken their antiretroviral or 2 hours before.
Bridget, just a quick question. With Stevens-Johnson syndrome and rhabdomyolysis, what have you found are easy ways to explain what the patient may experience from those, in a way that they can understand?
Right. So what I tell them to look for, and these are also listed on the discharge instructions, I tell them to look for a severe rash for Stevens-Johnson syndrome. Do you have a severe rash all over your body? For rhabdomyolysis, they're going to have muscle and joint aches and pains. And they most likely would have red urine because they're, there's blood in their urine, as you know. And then with, liver failure, potentially yellow eyes, yellow skin, dark urine, light stools, all the signs of liver failure. And, for kidney failure or compromise, or having less urine output, and, potentially water retention. And then allergic reaction, again, would be, something like hives or allergic reaction. And again, this is on the discharge instructions, but when I teach about these, I say if any of those happen, they're rare, but if they happen, you stop the medication and you either get to an ER, really, is what I advise. The chance of them, maybe they can get into their PCP in a few minutes, but that would not, typically that's not. And in terms of Truvada, so similar for the renal impairment, and then the Hep B would be probably something they don't feel, unfortunately. If they're having liver problems. Sometimes the stool will be sort of fatty. And just things you can have a fast heart rate with lactic acidosis, cold hands and feet, maybe short of breath because your body's trying to equilibrate its pH system. And I always tell them, when in doubt, again, these are rare, but when in doubt, you go in and you get evaluated. What I have found that what people notice first, and a couple times where I've had somebody have a reaction, it's either a rash or dark urine or light stool. I've never had anybody go into rhabdo, but it certainly is on the list. I'm wondering if Tivicay is used by any of your providers locally. This is the alternative to Isentress. The advantage is it's one time a day again, and it has a very similar profile. These class of drugs are have similar side effects because of their mechanism of action. So liver toxicity, of course, a rash, and people who have underlying hepatitis B or C, there's even a higher risk. And there are several, as you'll see here, drug-drug interactions. I've often worried about the drug-drug interactions because people are not good historians as to what it is that they take all the time. But I usually will highlight on the discharge instructions in yellow these parts that show like things that they shouldn't take and the dosing. So all we can do is try to do the teaching, and if by chance the facility where they're at has seen the patient before, they may have a med list in their system. Okay, obtaining the meds. So we've got uninsured, we've got people who maybe have insurance or they're sure they have insurance and they have prescription coverage because these are going to, this is a prescription coverage issue. And then there's always the I don't know what I have. So one shoe does not fit all, but there are great solutions out there to obtain the meds. Okay, and then there's also the process of obtaining the meds, going through all of these things, and then doing the follow-up and the discharge teaching. So these are kind of like the challenges. You got to get the meds, you got to teach the patient. Okay, so we'll go back to that. Anyway, the uninsured. So this is about obtaining free medication through patient assistance programs. All right. Each one of them functions individually. So we're going to, okay, we have a question here. Why would Tivicay be used instead of Isentress? What's the indication? So there is not an indication that would say, oh, it has to be Tivicay or Isentress in terms of the person's clinical picture or comorbidities. It is often just a institutional choice. In my practice, the only people that use Tivicay in the area up and around Portland is the Kaiser system, and that's just the choice they made. They're both first line treatment recommendations from the CDC, but most people prescribe Truvada and Isentress. I guess there is an advantage, with Tivicay in some ways if in terms of adherence. So some providers like that better because then you've got Truvada that once a day and you've got Tivicay that's once a day. So there's less opportunity to miss a dose because Isentress is twice a day. I got that right. All right. So where are we at in time here? We are. Okay. So I hope this is going to be helpful because we're going to kind of open up these forms and we're going to just talk through them. Now, there's going to be, again, a resource attached to the power presentation so that you can, and it's going to, address all the things I'm going to talk about. But I just want to point out and go through these. So this is for Truvada, okay? They have a list of all these things you're supposed to do, and most of it's sort of right on, but I've found a few things you don't really quite have to do. Okay, so the most important thing about filling out these forms is that everything is filled out. It's sort of like this, the SANE exam form. If you don't know the answer, you can write in, I don't know, or cross it out, or something of that nature, just to avoid this moving forward in a timely manner. So you apply patient labels, okay? And for our scenario, can they see this? Okay. So you see up here, number one, patient support that's being requested. You go to this one, Patient Assistance Program, PEP. And then you're going to make an X. And then I always write in afterwards for nPEP. And I put post-exposure sexual assault. The reason being is these programs, this is true for any of them we're going to go through, they're not just, they're primarily designed for people who have HIV and need, medication assistance, support in that regard. And so for us, we want to let them know that this is for nPEP because of getting it turned around in a timely manner. And because of the remainder of the information will be on there, it'll just make it clearer. So product name, see, this is the other thing. They only give you the option for treatment because this is how these programs are designed, or for pre-exposure prophylaxis, which we talked about earlier, where we're not doing that. We're doing treatment, but then I usually cross it out and I'll put treatment nPEP, post-sexual assault, just so it's clear. And then, of course, all of this needs to be filled out. I will tell you, I know that some people have your own systems, and so it's very hard for me to kind of pinpoint how everybody might work, but assuming you're the individual, the nurse, the SANE, that is responsible to follow up on this the next day, which we'll get into, or that day, and to contact the patient, I always fill in my name for alternate contact, my mobile, and then I put in SANE, okay? And you can authorize them to call. So people don't have any insurance, cross that out, and the patient is uninsured, no health insurance, blah, blah, blah. If they're on Medicare, which rarely happens, you have to put no. They will not assist for Medicare patients. It's a federal restriction. And then there's no phone number, blah, blah, blah. And then the prescriber information. I don't know about you guys, but most ER physicians, which will be filling this out, do not know their state license number, their NPI, their tax ID. It's important you get one of these. I find the NPR, the state license number, is most useful. And then you can put in the name of the facility, but I put myself here again because I'm really going to be the follow-up contact, right? And I stick my phone number on here as well. The ICD-9 code, and this is on your cheat sheet, but the ICD-9 code is Z20.6, and that's the code for contact with suspected exposure to HIV. So that's consistent with this is for nPEP. And then you got to get the doctor's signature for sure. They will not take it without. Patient stuff. And then the signature of the patient, okay? I don't know if they want marketing and to date it, okay? So then there's another page here. Again, make sure the patient's name, often whatever their income is, you can put that on there. If they're uninsured, chances are they don't have great income. Sometimes they say nothing. I'm living in my car. I can put patient homeless, no income. And this is, again, you don't have to memorize it, but you're going to check no. ADAP is actually a program for people who have HIV. That's another way to get assistance. And I don't know if somebody's applied for Medicaid. Sometimes I'll put I don't know, or I can put yes. Are they eligible? I don't know, because I don't know. VA benefits, I don't know. But I do put something in there. Have they tried to get something through the exchange? If they're uninsured, I just put no here, or if they're eligible. And these tie into those, okay? And then the patient needs to sign again and date it. So the next step is to fax this form. Oh, I have a question. Has insurance through their parents, but they don't want, find out about the sexual assault. Rebecca, that is such a good question. Rebecca asked, patient has insurance through their parents, but they don't want their parents to find out about the assault. Is it okay that they don't have to? They don't have insurance on these forms? Well, I'm assuming you're asking for somebody who's over 18, because you can't sign for these unless you are. It gets a little tricky because often, like somebody who's 22 and on their patient insurance, and I've had this happen and then be really devastating to the patient when she's 21 or something. And she checked in, her insurance stuff's already in the system at this particular hospital. And she just wanted like the prophylaxis and everything. And of course, we have the SAVE fund, but there's never a guarantee that something won't show up on their parents' EOB. And so you can try to do that if you're just trying to do what you can for this patient. If they're of age, but it wouldn't be exactly, within the legal parameters. And it is a challenge, actually. It is, yeah. And I have had that happen. And I think the best thing to do is explain to the patient that they're uncertain, you're uncertain whether or not, I always warn them there's a chance that something's going to float through the hospital, regardless of the nPEP. And I don't know, Nicole, what have you done in these cases?
Yeah, I mostly warn them that there's a possibility that something from the visit will end up on their insurance. But I don't like committing this to a webinar that's going to be posted, but I have occasionally fudged a form to try to get patients what they need if I know that that's the only way to get it to them. I guess it's probably not good that that's going to be posted online.
And so, Rebecca, actually, we're going to go through the next thing. Again, there's always a chance parents are going to find out, hands down. But if the person does have prescription coverage, okay, not just insurance, but prescription coverage, the next thing I'm going to go through is a step for people who have prescription coverage where we're going to print out and hand them a copay card at the time of exam. And we'll go through those next steps. So you wouldn't, if they have insurance, you really don't need to use this form. It'd probably be, you should use the copay card, which I'm going to describe next. So maybe let me know if that answers or helps answer that question. And then, okay, transient homeless population without a mailing address. How do you ensure they're going to get their meds? So yeah, so the mailing address part is for the next medication, Isentress, which we haven't talked about yet. And that's a really great question, Stephanie, because Isentress, unlike this, which we haven't finished, Truvada, Isentress gets mailed. And so, yes, there has to be a place arranged. And why don't we...
Well, quick question on that.
Okay.
Will Truvada still process application if a mailing address is not filled in?
No.
Okay.
They have to have a mailing address. So there's got to be some arrangements made at the time when the Isentress form is submitted, which we haven't gotten to yet.
Oh, no, I mean for the Truvada form that we're going through, because it is important to fill it out all the way. If the patient doesn't have a mailing address to fill in.
Oh, you can put in. Okay, so Stephanie, just want to clarify because you're talking about a mailing address, okay? And I assumed you were asking about the mailing of Isentress, okay? And maybe you were not. My apologies. But if someone is homeless with this form, that's not. I mean, it's a problem for the poor individual, but you can put on here homeless because they are not going to have the delivery of the medication. They're going to, and we haven't gotten to that step yet, how they obtain it, but this form can be sent in and the person's homeless. That's just what you have to write in.
And then we'll address that question again when we get to Isentress, because that is a different process as well.
Okay, so bottom line is you take this form, you copy it because you're going to give one to the patient at discharge. You fax it in, okay? And then if you're fortunate enough to be in the window of time when Advancing Access, which is this program, is open, which is Monday through Friday, 9 a.m. to 8 p.m. Eastern Standard, you can then just call and follow up with them at that time. But many of our exams are in the middle of the night and they're not open. So you still fax it off and you call this patient assistance program the next business morning. So if this is Friday night and, then it's Monday morning. If this is Thursday night, when you're faxing it in, you call them Friday morning. So the very first business day, and you will confirm that they've received this, and it will be reviewed with a representative on the phone, okay? And then, and I have not yet I've always had them approved. The person on the phone is going to provide you a list of like the PCN, the group number, the ID number, that type of information, okay? They'll give it to you verbally, and then you will call the patient and you will give them those numbers, okay? And with this medication, and I guess maybe my slides are a little out of order here, you've given the patient at discharge a hard copy of the prescription of Truvada, and it's going to be for 30 days, okay? Again, these programs are set up for people who have HIV. So even though we're sending somebody home, maybe hopefully with a few days of a take-home pack, and even though the treatment course is 28 days, the provider has to write the prescription for 30 days of treatment. So I always tell the patient that they're going to have leftover that will need to be destroyed. It's just the way this program is structured. So you fax this in that day or the next day, you call Advancing Access, they give you the PCN and the ID number, etc. You will then call the patient and you verbally give them those numbers so they can write it down. I tell them just to write it on the script, which they now have in their possession, and they take it to a pharmacy to get it filled. Okay, and I'd always advise they go to a bigger pharmacy so they have HIV meds. And I warn them sometimes it takes a day or two for pharmacies to get them in. So don't wait to the 11th hour. Take it in immediately because you might have to wait a day or so to get the meds. And hopefully they have enough take-home pack to get them, to that window. Does that answer? Does everybody feel like they understand that? And if not, we can go back. Just let me know. So, okay, hang on one second. Yeah. So let's go to the copay card for. Let's stay on the same med. Okay, so this is the other part when you were talking about the younger individual and a person on their parents' insurance. Not that that's the only way this applies, but the other thing that Truvada's patient assistant has is what is basically, it's a copay card. Okay, and while you're at the hospital, like if you know that person has prescription insurance, while you're at the hospital, if you can ask to pop on one of the computers. We'll get you the link. You can open up, the internet web browser and go to this site. And it is so quick and fast. There's, they ask a few questions. Are you a resident? And you're doing it on behalf of the patient, obviously. Do you have Medicare or Medicaid? No. Do you have no? Are you receiving prescription benefits from federal stuff? No. And then you go and then you push I understand and you submit it, and the next page pops up, and it is it's very basic information. It's like the person's name, date of birth, what medication, that, and then you submit it, and they pop up a page that is a coupon card. Here, you want to try it? All right.
So super quick and easy there. You hit submit.
Oh, it must agree with this.
My bad.
Okay, yeah. All right. Okay, and let's go to this. Copay coupon program. Oh, that's where I thought I just was. Okay. And I do not have there's three options. You enroll. I don't have a card and I'd want to enroll, right? Or if somebody lost one or, whatnot. Oops. Sorry, it's my PCP. Oh, so we got kind of screwed up there. So why did it do that? That's interesting.
Maybe because I hit no originally.
Oh.
Okay. Let's do this again. I hit no. Yes, I understand. Submit. There we go.
There we go. So here's what you fill out. The person's gendered. What meds do you need? Okay. And you push I understand. Okay. And you submit it. And basically like a regular old coupon pops up on the screen, and you can print it and hand it to the patient, and they can take it with the prescription you've just given them from the doctor for 30 days, and they will go to the pharmacy and they will not have to pay anything out of pocket. So I want to have you guys look at this. You see how much it covers in copays per year? That's because this is designed for people who, let's see, where is my Truvada? Okay, so 4,800. Because it's designed for people who have HIV, right? And they're going to need copay assistance for the whole year. But you can use that, not that they need it, but the whole $4,800 in for that one prescription. Not that they'll need it. So no matter what their copay is, they're going to, that copay card assistance is going to definitely cover what they need. What? So is the online portion? Oh, no. Okay, so I'm sorry, Michelle. She asks, is this online portion required in addition to the actual form we just went over? No. So there's two different scenarios. The form is for people who have no insurance. That's the form that gets faxed in, and then the next day you follow up and talk to a representative on the phone and get the BIN and the PCN. Okay, this program, just so I'll finish that thought, is for people who have insurance, RX coverage, and just need assistance for the copay.
And just to clarify, if the patient has insurance, but that insurance does not include any prescription coverage, you will still use this enrollment form for those who are uninsured.
Okay. So let's go to Isentress.
I accidentally closed out of the Isentress window, so just got to get it back here. Let's see. History recently closed. There we go. There we go.
Okay, I'm sure you'll be happy to hear that Isentress works differently. So, these systems are, all very independent of each other. So bear with me. And again, this is all written down. So if it's swimming in your head, you've got step-by-step cheat sheet that it's going to be attached. So this is for Isentress, okay? Isentress has it's a little quirky, I think, the new system. But basically, this form, it's good. This form is used for both insured who need copay assistance or uninsured. So there's only this to be completed. I want you to note their fax number is nowhere on this form. So I have it on the instructions because when you're there and you're ready to fax, you realize you don't have it. My little trick was to write the fax number up here before I made my copies and had my stash in my bag. The other thing that you need to do for this before we get going on the top is I also wrote across this top for nPEP, post-exposure sexual assault, need overnight delivery. And this will make sense in a little bit. Okay, but I would do that and then make my copies. So again, everything's got to be filled out, right? Okay, then it's if you either what the income is, if there is any, okay? Note that here you're going to be marking where the product, they deliver this product. This is the one that we were talking about earlier. Unlike Truvada, which the patient takes a prescription and shows up at a pharmacy and gets it filled, this one gets UPS'd to the patient or whoever can receive it someplace, okay? And you can put, if you have prescription coverage, yes or no, because this form works for people who need copay assistance and who have no prescription coverage. So they're differentiating it there, okay? And then you got to have the patient's signature. And again, so this is one of the other things that are very different with this. The patient's not going to go home with a prescription from Isentress. This form serves as the prescription itself, okay? So fill in all the names and whatnot, and so you're going to have to write in, Isentress 400, 30. So you still, Isentress is twice a day, so it's going to be 60, right? Because these have to be filled out like the person's going to be taking it for 30 days. So 60, and then one pill twice a day, and then no refills, and then I put over here for 28 days, okay? So here's that doctor's state license number and date. They need that. They're not going to fill it if they don't have the doc's signature because this is the prescription, okay? Dispense is written, okay? And then fill in if the patient has any of these conditions and the meds. And then the doctor's stuff, I again put myself as the contact name, my email address, and I fill in my phone number, and I'll put over there, SANE. Because the doctor, if they have to call the doctor, or they think they need to call the doctor the next day at the ER and he's not on shift, and nobody's going to know what to do, right? And then again, the provider's signature, okay? What's similar about these two is this form will now be faxed into the Merck patient assistant. This is Merck Helps. And they will, the next day, unless it's business hours. If it's business hours, you can call, and that's wonderful. As soon as you fax it, you can call. But assuming it's not, you call the next business day, first thing. You confirm they've gotten this fax, just like before. You review. Sometimes they'll have some questions, etc. And then you can find out from them about when the product will be shipped to the patient. So, and again, this is written down, but basically the rules for this are that if the Merck Patient Assistance Program gets your fax by 1400 Pacific time, they're going to be able to overnight that same day. So if it's Monday and before 2 p.m. that you send it in, the patient will have it UPS to their house the next day, meaning Tuesday. Okay. If it's after 2 p.m, then it's not going to be sent out until Tuesday night. So basically it'll arrive in 48 hours instead of 24. So just to go back to the top of this form, I want you to know the reason you need to put in and make a note of, for nPEP need overnight delivery is because this program is, again, structured for people who have HIV. And when they ship out med to people who are HIV positive, it doesn't have this urgent timeline. They don't need it the next day. They can get it in 3 days. So you just don't want these guys to be unaware that you're trying to get it there ASAP. So then the other part is, I find this one's a little trickier. You've got to make sure you have the patient's phone number. You got to make sure you've got an address where someone will be to receive the medication, because UPS will not leave it. And so the next day, once you obtain the shipping information, estimated time, when it's going to be there, you call the patient, you run through it, you make sure somebody's going to be there, and then hopefully all of that works. It works really most of the time. Okay, so the homelessness question for this, and maybe that's what you were asking earlier. Yeah, that's tricky. So what I have done in those scenarios is sometimes people who are homeless have either a place that they like an address, a mailing address where somebody is allowing them to have their mail sent, or if there is a facility that's assisting them that they go to, like some type of a mission or shelter. Of course, getting that information at the time of the exam so that you know it's correct on the form can be a little tricky. I've even had patients call someone they felt comfortable calling to ask if something could be sent to their home, and be delivered there. That so that we had a rock solid address to give to the Merck Patient Assistance Program. Does that answer the question, I hope?
And in occasions where my patient has not had a family or friend or other contact with a mailing address, I have sometimes had success using the address of the hospital or the facility itself. That's not my preference. I would prefer a friend or family member, just because if it's being sent to the facility, there's a lot of coordination that's required to make sure that everyone knows what's going on. I'm talking like signs all over the place an estimate of when it will show up, because you don't want those meds to show up at the hospital and have someone not know what they're there for, or reject, not accept the medications, or put them somewhere where they can't be found. So, but when it's really been push come to shove and there's been no other option, I've done that, and I've just coordinated with the charge nurse and the front desk and the provider and administration, and just everyone, trying to make sure that everyone knows what's going on. So that is an option as well, although, like I said, wouldn't be my first choice.
Why don't we go back to the... just the PowerPoint. Sure. Oh, guys, there's one other thing. Wait a minute. That was you were referring to. Okay, great. Thank you, Stephanie. One other little caveat with this form, of course, there's always caveats, is if the patient is, this is what's odd about it, no matter what, if the person has prescription insurance and they want assistance, like because the copay is too expensive, or if they're uninsured, they still get the medication completely for free. It's even if they have insurance. But if it's a situation where somebody has prescription coverage, you're also supposed to, it's up here, the Viva, I think you have it open.
I actually don't think we pulled that one.
Attestation, yeah. Okay, so there's another single page form. It's called an attestation. This will be attached, and it's kind of repetitive, but it's a very simple form. Just the patient has to sign it, and it just states that they want this assistance because of hardship for copay. Regardless, everybody gets it for free, and they get sent to their house. So.
Yeah, sorry, that was my bad. I didn't pull it up, but yeah, that will be included. And also, because I realize it will take a week or two for this to be posted online, what I can do in the meantime is, in the next couple of days, everyone who's registered, or everyone who's on the webinar today, I'll go ahead and email out those handouts for you, so that you don't have to wait for it to be posted.
Mm-hmm. We got a list of,
yes.
Okay, guys, some of you may be familiar with these. This is the discharge instructions, or sample discharge instruction that's on the Sexual Assault Task Force website and available for your use, or however, or you can adjust as needed. It's almost a little bit of a cheat sheet for us too. It's intended to educate the patient, but as you see, the things that we need to take care of are here. Like, who are they referring to? Schedule an appointment within 3 to 5 days. You will have future labs and appointments, which is something you'll talk to them about. They see a doctor in 3 to 5 days, but then they will additionally, of course, continue being monitored during treatment. I tell them to bring all their current meds. So it's really a good trigger for you. I have concerning symptoms, including the uncommon side effects listed below, immediate attention. Okay, I advise that they take, because they have to take the medications at the same time every day, take your medications at time as prescribed, set a watch or cell phone alarm. And now this will go through the meds, the side effects, okay? And I will fill in I'll check whatever applies. Not all of them will apply, but let's say I got a take-home pack for 5 days. Lucky me. I could check that and then put 5 days of treatment, X number of pills. I also gave them a prescription for 30 days of treatment. They're going to get X number of pills, because that's what they get, right? And let's say I've either submitted a form to try and get the rest of the meds for free, right? And say, once approved, we'll contact you with the necessary information to take to the pharmacy, along with your prescription. So the things we've talked about are pretty much outlined here. If you don't have to do this frequently, it's not a bad go-to cheat sheet. Or maybe I don't fill out a form because they've got prescription coverage. So instead, I would check, you have been provided a copay assistance card. Take your card to the pharmacy, and the card will cover all copay costs. And then I write down when was their first dose, date, and time. And it's true for all of the meds. And hopefully that will help. I don't think we should get to that. It's too much. Yeah. Okay, let's see. So for Truvada, the copay is a separate program. For Isentress, you fill out the same form for patient assistance. Yeah, I know, it's odd. You're absolutely right. Rebecca asked for Truvada, the copay card is a separate program, and Isentress, you fill out the same form for patient assistance and copay. Is that correct? Yes, that is correct, Rebecca. And yeah, it's just to clarify for Truvada, it's they just sort of have two. It's still the patient assistance program, but they've got one arm that addresses copay stuff, and another arm that addresses people who have no insurance. But yes, it's like two different functions. You don't have to do both. You do one or the other for Truvada, right? And then for Isentress, there's just that one form. I'm going to skip Tivicay because it's I will have all the information in. It really operates the way Truvada does. And I think everybody's head's probably spinning. Screen sharing is paused. Did you want to? Okay. Give us a second. We're having a check here. Move this window away. Okay, so we'll go back to the PowerPoint. Oh.
Sorry, there's a window open apparently that's messing with my stuff. So give me just a moment here.
Okay, close it.
Yeah. Oh, and let's go ahead and show this. And this, for just to show you guys here, there we go. This is the cheat sheet that Bridget really kindly made up for us that we'll be attaching to the webinar posted online, and that I'll email out to all of you who are listening to this live. So just to show you what that looks like there.
Yeah, and so it's the main points that I made, and a few little tricks of treatment. Make reminder of 30 days of treatment. We've got the ICD 10, I think we're at now, or something code, and it will have the links to all of these forms or coupons and the steps. Okay, so hopefully that, and it's also going to have the attestation form that I mentioned for copay with Isentress, and all the phone numbers will be on it too for the contact the individuals who are helping us.
Okay, so let's see if I can get this thing to stop wigging out here. Brilliant. Okay. Sorry. Okay.
There we go. We'll go back. Okay, challenges. Well, we've already talked about some of these things, but and I'd love to know if you guys have the same thing. The take-home packs, seems that some facilities are consistently making them available for whatever amount. Others have changed their programs or will not give take-home packs. Sometimes they can do it under more of what's it called, fill, the compassion fill. Sometimes you got to go through the social workers or whatnot. But starting the medication immediately is very important. That said, I've always managed to get something to get them a take-home pack, right? But if you are to give somebody the first dose of Isentress and the first dose of Truvada, and they don't have a take-home pack, they need to take the next dose of Isentress in 12 hours, and they will not have that delivery in 12 hours, as you might expect. So when is this the worst case scenario? Well, it could be Friday night, and then, it's going to be Monday before you talk to the assistance program, and then it's probably, they'll get it Tuesday. So that's a situation where somebody's going to need meds for 4 days. So if anybody ever has some creative ideas in terms of consistently, I think the best thing to do is to know your institution's policy so you know what you're walking into, so that you can work out all that timing. I think the next thing is connecting with patients that next day. If you're doing the medication assistance, you can give them the Truvada bin numbers, et cetera, and coordinating the delivery of the and the location of Isentress. There you go. Okay. I think medication teaching with a fatigued patient is a challenge. I use the discharge instructions and do some highlighting, and if there happens to be someone there who is a reliable support person, I try to get them to listen. I will mark on the bottles what's what, just to try and get them through those first few days until they get to see a provider. And then if for those who don't have providers, it's figuring out a recommendation for this person to get a provider for the follow-up care that they need while on treatment. So a couple solutions, of course, be knowledgeable. We're trying to do this teaching and keep them safe. Know the facility take-home pack. I think you should, whatever form you use, you really need to have written nPEP discharge instructions. There's a lot of important information on there, and we know they're not absorbing it. I always give the patient a copy of the completed patient assistant forms that you faxed. It comes in handy on multiple occasions, and then they've got in front of them, what you've completed. And then before you depart, make sure you have a plan in place on how you're going to communicate for the next steps. It does help to have an established relationship with the advocacy team that's supporting you. So they've got a sense for what's going on and keep them in the loop, because sometimes patients will call them and as in lieu of waiting to hear from you or something of that nature. So that the advocacy people know to turf it over back to your direction, because no doubt you're working on something and the patient maybe didn't quite absorb it at the time of exam.
And the more that you have all these things set up, like knowing your facility's take-home pack policy and the relationship with advocacy, the more that you have that set up in advance, the more it really behooves you, because as Bridget mentioned, these things rarely seem to come up during business hours. And so trying to figure these things out in the middle of the night is much harder than figuring out in advance when you don't have a patient waiting right there for you. And then it just really makes things a lot easier.
So one resource, we didn't talk about this. Okay, this is something, I don't know how many of you are aware of it. We talked about the federally qualified health centers and these organizations to get this type of certification has to meet certain criteria for the facility to get the benefits and whatnot. But basically, and this list is always updated, it's the Oregon Certified Federally Qualified Health Centers. We're going to give you the link to it. It's ever changing. It has, as you'll see, let's see, where am I? A very long list in all the different counties of these centers. And these centers, they do have this obligation, and they have primary care provider. I mean, there may be one that says just pediatrics or for mother-baby, but by and large, they're primary care. They've got MPs and PAs and doctors and whatnot that are running them with all these resources also at the same facility. And so if you're, just trying to figure out where somebody can be seen in 3 to 5 days, this is a great list. And I think in particular, people who are in more rural areas or like not the non-urban areas, if there's only one or two of these programs in your vicinity, you might be able to just set up a relationship like in advance to say like, hey, we're going to have these people. If they're not insured or they're insured, or they don't have a provider, we'd like to, kind of smooth that referral process so that you're not recreating the wheel every time the patient tries to go and get a new appointment, or if you're assisting them. I think it just makes it easier. Did somebody ask a question? Yes. So yes, Kaiser. The question is, how do you know what happened? Do you know where Kaiser patients fall into this application process for meds? I recently cared for a patient who was a Kaiser patient, and when the physician called the pharmacy, and all the meds were covered. So, Kaiser's a collection of both the insurance company and the medical provider, et cetera. If they're a Kaiser patient, you're absolutely right that they could potentially. So in this case, let's say it's a Kaiser patient. There's a pharmacy open in at the hospital where you are. There can be arrangements made where that patient either walks over with the scripts themselves, okay, and gets them filled because maybe the doctor's already called and gotten things, straightened out, or maybe they fax it over in advance and the patient can walk over there and simply get the 30, well, it wouldn't be 30 in this case because they're not going to be using any patient assistance, but the 28-day course. And they really could take their first dose from that medication prescription. That's rarely happens unless you're at Kaiser. If they're at Kaiser and they're not a Kaiser patient, that will not happen. I've had that scenario multiple times. The other thing is that sometimes Kaiser they'll definitely get you a take-home pack if you're one of their patients or clients, utilizers of the plan. But sometimes they won't fill out the all the other stuff or give a prescription for the remaining treatment. They want them to see their PCP the next day, who they want the PCP to handle it. So there's times where, like Providence is another example, the ER docs, by and large, do not like to write for the 30 days so we can get things moving with financial assistance. They prefer to give a take-home pack, but they also have a system in place where the patient can be referred to ID within 1 to 3 days. And then ID nurses, who are fabulous there, take over this process. And they magically have more meds somewhere there than they were able to do. But you have to communicate with them. So part of this is I call it part art, part science. And know that certain institutions have their own means of managing it. By and large, you end up having to send these forms.
And you may also run into a situation where you don't know your patient's insurance or their prescription coverage. And so what I always do in that case is I just get the most complicated part filled out. So I'll go ahead and do the uninsured form for Truvada. As Bridget mentioned, for Isentress, it really doesn't matter. And that way that groundwork is there in case it's necessary.
Okay, real considerations for nPEP. Well, there's fewer pharmacies probably with HIV medications in stock. Potentially fewer local providers with decreased access for somebody to get in 3 to 5 days. And of course, the ongoing medical management. Public transportation can be a challenge for, there's less of it. And so patients can't get to their appointments and provider visits. And Availability of nPEP medication take-home packs, I don't know, but I wish I'd love to have had that information if that's a challenge at some of the other hospitals outside of the metro area. We do everything. Okay, so this is just an idea of the forms and the things that will be on there. Does anybody have any other questions or scenario they want to share? Okay. Okay, we have a question here. What would you counsel a patient for the risk of HIV if they were assaulted vaginally by an unknown assailant and experienced bleeding afterwards? You know, it's tricky what our relationship is. I know many times patients will say, like, what would you do? And frankly, I give them the honest answer. I say, I don't know in a lot of situations. It's something I've thought about. Really, the most important thing is to, I think, lay out the piece of data that really applies to that scenario. So vaginal bleed, assuming that's from trauma as opposed to menstruation, means that there is a compromised mucosal lining and therefore a portal, more of a portal for potential infected fluid to enter. So I would use the data that's on the, receptive vaginal, and then I would make mention that the fact that there is a tear, assuming that's what it is, does increase that risk. But I also take the lead kind of from what I think the patient's wanting. Like sometimes they feel very strongly about it, even if there isn't something maybe as obvious as this trauma, or if they, they just want nothing to do with it. I present the data, and at times I think, boy, this is a scenario that could really warrant nPEP. But I take their lead. So I try not to be like counsel them one way or another. I try to do that. I know it's kind of a fine line, but I really just try to do the data. And I write down a number because there's just so much information. And then I let them decide. Now I can tell you there's been some scenario where people were just exhausted. And let's say it's Sunday night or something like that. And the assault just occurred. Really, the goal is to start the nPEP right away. But if they're ready to pull their hair out and they're just done, if I know I can get them in the next day to see their provider or something like that, because they really think they want to do it. I've given people all the paperwork if they need it and whatnot, and said, if you want to sleep on this overnight and you can see your doctor tomorrow, it's very hard to make a decision in those situations. So if there's really a window of time and it looks like they're struggling, I've offered that a handful of times.
Yeah, I agree with that. I just want to say, because we are at time, we'll continue to hang out and answer any questions that come up. But for those of you who need to leave, I wanted to let you know, thank you so much for sitting in on our webinar today. Like I said, I will email out these handouts and resources and the PowerPoint as well, so that you guys all have that. It may take a few days. We'll also be emailing out CEU certificates, and you should get those within the next week or so. And then for those of you who are listening to this off of the website and are not watching this live, there will be a post-test link that you can fill out to get CEU credit as well. So you will get that whether or not you're listening live or listening in after the fact.
Okay, one thing, guys, I want to, let's see, my phone number, Nicole's on here somewhere too as well. If questions come up and you need some help and you don't have another resource you go to or whatnot, you can always reach out. We want to try and simplify this as much as possible. once you get through it a few times, it's not actually as confounding as it seems. But I'm so glad you guys are here, and reach out any time that you need assistance.
Thank you guys very much.